The purpose of this training video is to introduce first-year medical students to taking blood pressure and assessing pulse, and also introducing you to the steps of the cardiovascular examination, as well as reviewing some surface anatomy relevant to the cardiovascular examination. And of course, before we begin any exam, we always wash our hands, so I'm first going to wash my hands. Let's first review the 4 factors that influence arterial blood pressure. First, there's left ventricular stroke volume. Second, there's the distensibility of the large vessels and the aorta. Third, there's peripheral vascular resistance. And finally, fourth, blood volume. A change in any one of those 4 factors will influence the arterial blood pressure, whether it's systolic or diastolic. When assessing pulse, we normally use the radial pulse at the level of the wrist. It's superficial to the radial bone and lateral to the flexor tendons, which can be identified if you have the patient flex their wrist. By placing, again, the pads of your fingers just lateral to the flexor tendons, you can palpate the radial pulse. By simply counting the pulse for 15 seconds and multiplying by 4, you get the beats per minute. If you're unable to assess pulse at the radial level, you can also assess the pulse in the antitubular fossa by assessing the brachial artery. If you ask the patient to make a muscle, you can identify the biceps tendon, and then when they relax, just put your fingers, pads, medial to the biceps tendon, and you can identify the brachial artery and take the pulse there. Finally, you can also assess pulse by assessing the carotid artery in the lower third to lower half of the neck by simply placing your finger pads just medial to the sternocleidomastoid muscle. You'll note when you take the pulse, the symmetry of the pulse. When you're assessing radial artery pulse between the right and the left side, there should be a symmetry and you should feel both pulses simultaneously. You'll also, again, note the rate, what's the beats per minute, and you'll note the rhythm. You'll try to determine if the rhythm is regular or if the rhythm is irregular. If the rhythm is irregular, you'll try to determine is there any pattern to the irregularity. Is it sporadic or is it totally irregular? And by that I mean, is every third beat come early? Is there a pattern? Or is there a pattern that the irregularity varies with respiration? Does the pulse speed up with inspiration and slow down with expiration? Or finally, is there no pattern whatsoever, in which case the pulse would be irregular, and that's always an indication of atrial fibrillation. If the pulse is irregular, you need more than 15 seconds timing to assess the pulse. In fact, if you're not sure, you may need to check the pulse for a full 2 minutes. You, of course, need a sphygmomanometer with a blood pressure cuff. And of course, a blood pressure cuff is not one size fits all. The largest blood pressure cuff is known as a thigh cuff, although this can be used on a patient who has a very large arm. The width of this cuff is approximately 18 centimeters. The next largest cuff is known as a large adult blood pressure cuff, and this one is approximately 15 centimeters wide. Then we have the normal adult blood pressure cuff, and it is about 12 or 13 centimeters wide. And finally, we have the smallest blood pressure cuff, which can be known as a pediatric or small adult cuff, and this one is about 10 centimeters wide. To determine which cuff is appropriate, we need to measure 2 different variables on the arm. We measure the width of the blood pressure cuff against the patient's arm. The width of the blood pressure cuff should be approximately 40% of the circumference of the arm. Also, determining the total length of the bladder of the blood pressure cuff, which is where the tubes come out of the blood pressure cuff. When you wrap the blood pressure cuff around the patient's arm, it should approximately be at least 80% of the circumference of the arm. The length of the bladder does not represent the entire length of the blood pressure cuff. Notice where the tubes come out of the blood pressure cuff, and notice that that area is thicker. This is where the bladder of the blood pressure cuff is, and it's the length of the bladder that we're interested in, that should be 80% of the circumference of the arm to be the correct size. So a normal adult cuff fits Dad just fine. We'll go ahead and place the blood pressure cuff snugly on his arm. You'll notice I'm approximately 2.5 centimeters above the antecubital fossa. Bates will recommend that you check the blood pressure with the bell of your stethoscope, but I think you'll find most physicians at Loyola use a diaphragm to measure blood pressure. Again, the blood pressure must be taken on skin. It shouldn't be taken over an article of clothing or the patient's gown. The patient should be relaxed and calm. Don't check the blood pressure of the patient just rushed into your office, they're late, or if they're crying, because of course the blood pressure will be elevated. First, we're going to check the blood pressure by palpation. Simply identify the radial pulse, tighten up the valve in the blood pressure cuff, and by watching the sphygmomanometer, I'm going to determine when I stop feeling the radial pulse and blow up the cuff approximately 20 beyond that. And I felt the pulse disappear about 110. As I released the air from the cuff, I felt it return about 110. This tells me that the systolic blood pressure is approximately 110. So when I go to auscultate the blood pressure, I know I only need to auscultate above about 20 millimeters of mercury, approximately above 110. I don't need to blow the cuff all the way up to 200 and to hurt his arm. You notice that the brachial artery should be about at the level of the heart, but the patient's arm should also be relaxed, so you as the doctor should be the one holding the arm up. Don't ask the patient to hold their arm up, because that again can falsely elevate their blood pressure. So close the cuff and the valve, and then slowly blow it up again, about 20 points again beyond where I felt the blood pressure disappear by palpation. I'm going to slowly release the air. The point at which I first heard the blood pressure pulse return was 116. The pulse disappeared at approximately 76. So the blood pressure by auscultation is 116 over 76. And of course, I'm going to repeat this in the other arm, both by palpation and also by auscultation. And again, it's important to use a right-sized cuff, because if the cuff is too small, it'll falsely elevate the patient's blood pressure, and you may diagnose the patient with high blood pressure or hypertension incorrectly. So let's finish up with blood pressure by reviewing some of the common errors in assessing blood pressure. First, again, just checking the auscultation over an article of clothing or a gown is incorrect. Using a cuff that's too small will falsely elevate blood pressure. 3, not elevating the arm or the brachial artery to the level of the heart would cause an error. 4th, if the patient just held their arm up themselves, they'd be contracting their muscles, and that would falsely elevate blood pressure. So again, you as a physician needs to help elevate their arm to heart level. And also, if the cuff is too low on the arm, you'll occlude the brachial artery and be difficult to hear it. Next, if the patient's not relaxed, if they're upset or crying. And then if you deflate the air from the blood pressure cuff too quickly, the air will move down so fast you won't be adequately able to tell when the diastolic and systolic blood pressure actually are at. Now that we've completed blood pressure, let's review some key surface anatomy that's relevant to the heart exam. And Thad, if you could lower your gown for us. As you remember from the thorax video, there's a few key vertical lines that are important. First, there's the mid-sternal line, then the mid-clavicular line, and of course we use the clavicles to help us identify the mid-clavicular line, and the anterior axillary line. Also important is the sternal angle, or the angle of Louis, which is the bony ridge in the manubrium of the sternum, because just lateral to that is the second rib. And we use that to count ribs inferiorly to locate things on the chest wall. And then the costal angle is found in between the costal margins anteriorly. and the epigastrium is in this area. So why do we examine neck veins? Measuring neck veins lets us estimate what the patient's right atrial pressure is, and that helps us to assess what their patient's volume status or hydration status is. To get an exact measurement of the patient's volume status or hydration status, we need to do an invasive procedure which involves risk to the patient as an expensive. So instead we just use the height of maximum pulsation of the internal jugular vein to assess for this. If you look closely at the neck veins, you'll notice that there is a pattern of 2 waves and 2 descents per heartbeat. The A wave comes just before S1 and is the highest pulsation, and that represents atrial contraction. The X descent follows the A wave. Next comes the V wave, which is right before S2, and this represents atrial filling. This is followed by the Y descent. You may need to listen to the heart with your stethoscope while you watch the neck veins. The A wave comes just before S1, and the V wave coincides almost precisely with S2. Or you may need to palpate the left carotid artery while you're watching the right internal jugular vein to identify the timing. Remember that there's only 1 pulse per beat from the carotid artery, whereas there's 2 venous pulsations per beat, the A and V waves, from the internal jugular vein. Let's talk about examining the neck veins. This is not an easy examination step to learn. The position of the patient is important. Bates says to have the head of the table elevated to 30 degrees, and the Loyola 65-step physical recommends 45 degrees. If you have difficulty assessing the neck veins, you may need to raise or lower the head of the bed to help find the neck veins. The patient's head should be turned slightly to the left, and the physician should be on the patient's right side in the classic examination position. Again, the area we're going to be looking at is just above the clavicle at the base of the neck, near the sternocleidomastoid insertion into the clavicle. First, let's again identify the external jugular vein by pressing just deep or beyond the clavicle. Again, we can see the external jugular vein easily distended with this maneuver. But again, that's not what we're interested in. The internal jugular vein pulsation doesn't appear as a vein or as a column of blood. Instead, we see the pulsations arise through the skin and subcutaneous tissue. What you notice is the skin is kind of lifted up in 2 pulsations per beat, sort of in that manner. Sometimes it helps to look tangentially or to use an indirect light source to increase the shadows to find the pulsations when you're first trying to do this. It's always better to use the right internal jugular vein because that's a more direct route or channel to the right atrium than the left internal jugular vein. Remember, what we're looking for is a point of maximum pulsation. Once you identify the point of maximum venous pulsation, you need at least 1 ruler and 1 other straight edge. Put 1 ruler in line with the point of maximum pulsation, then put the other ruler at the sternal angle and measure what the reading is on the ruler that's resting vertically on the sternal angle. Normally, that reading will be 1 to 3 centimeters or less. To estimate the right atrial pressure, always add 5 to your measurement. Again, this is a difficult technique to master and takes practice, so don't be too rough on yourself if you have trouble identifying this initially. Let's now review some surface anatomy that's relative to the heart. The heart lies in the mediastinum, deep to the sternum. It also lies to the left of the midsternal line at approximately the 3rd to the 6th costal cartilages. The base of the heart is just inferior to the sternal angle. The apex of the heart, or the tip of the left ventricle, lies at or just medial to the midclavicular line at the 4th or 5th intercostal space. The precordium is the area of the chest wall that overlies the anterior surface of the heart. The heart is divided into right and left sides, but the heart is vertically rotated so that the right ventricle is mostly the anterior precordium. In fact, most of the precordium is made up of the right ventricle. The right atrium is at the superior border of the right side of the precordium, and the left ventricle represents a small area at the left side of the precordium. The left atrium does not have a projection on the precordium, and in fact lies posteriorly in the mediastinum. To position the patient for the heart exam, according to Loyola's 65 steps, the table should be flat. According to the Bates textbook, the table should be elevated to 30 degrees. Either way is fine. But the examination should always be done in skin and not over a gown or an article of clothing. And of course, the doctor should always be on the patient's right side, and the room needs to be quiet. As with any examination, we first begin by inspecting the precordium. We look for any lifts or heaves that might occur in the parasternal area. We also try to see if we can identify the point of maximal impulse just by inspection. In some patients, we can do that. Also, after we've finished inspecting with the patient supine, sometimes it helps to find the PMI by having the patient roll 45 degrees to the left side. And at that point, sometimes it's easier to identify the point of maximal impulse right there. Okay, you can lay flat again, Thad. If rolling over on the side isn't enough to bring the PMI out, then you can also ask the patient to exhale fully and hold their breath for a few seconds while you look for the PMI. The second part of the examination is palpation. For palpation, it's recommended you use the base of the fingers or the metacarpal phalangeal joints for palpation. And there's 5 different locations that you need to palpate. You palpate in the aortic area, or the right second intercostal space. Next, in the left second intercostal space, or the pulmonic area. Then, in the left parasternal area. Then, towards the apex of the heart, or where the PMI is, in the 4th or 5th intercostal space, in the midclavicular line. And finally, in the epigastrium. When you're palpating, you're trying to identify if there's any lifts against your hand of the heart as it contracts. The PMI will feel like a gentle tap or brief thrust against your hand. Some texts advocate using the finger pads to feel in the left parasternal area. Once you identify the PMI with the metacarpal phalangeal joints, you further identify it by using just your finger pads. The PMI can be characterized by diameter, duration, and amplitude. Normally the diameter is less than 2.5 centimeters, or 1 intercostal space. If you have to lay 2 or 3 fingers next to each other to feel the entire PMI, then the PMI diameter is enlarged. Also, feel for the duration of the PMI. And you need to listen or auscultate to the heart while doing this. Normally, the sense of maximal impulse lasts for less than 2/3 of systole. If the impulse continues all the way through systole to S2, the patient could have ventricular hypertrophy from chronic hypertension. And finally, feel for the amplitude of the PMI. Again, it should just be a gentle tap against your finger pads. If the amplitude feels very light, the heart is probably contracting less vigorously, as happens with a dilated cardiomyopathy. If the amplitude is increased or vigorous, that can sometimes be seen in high cardiac output states such as severe anemia or hyperthyroidism. Again, if you can't feel the PMI with the patient supine, again, you could roll over to your left side about 45 degrees and exhale fully. Again, this makes it more obvious, the PMI, by this maneuver. Okay, you can lay back. Sometimes the patient has a very muscular chest wall, or a patient who's very obese, or a patient has a very increased AP diameter of the chest, as happens with emphysema. The PMI cannot be palpated. If you can't palpate the PMI, another way to identify the left heart border is by percussion. And this is a step that's not normally done, but with the patient supine, in approximately the 4th interspace, begin percussing from about the anterior axillary line and move medially till you hear the resonance of the lung change to dullness. Do you notice the change at that point? Let me do that again. That dullness would be where the left heart border is at. And again, if you don't hear that in the fourth intercostal space, you can go down to the fifth or above in the third intercostal space to percuss for the left heart border. You remember that the normal heart sounds arise as the heart valves close. S1, or the first heart sound, represents the closure of the mitral valve and the tricuspid valve. S2, or the second heart sound, represents the closure of the aortic valve and the pulmonic valve. The first and second heart sounds define systole and diastole, with systole being the time between S1 and S2. As a general principle, right-sided valve closures occur slightly later or after left-sided valve closures. For example, the aortic valve usually closes first, then the pulmonic valve closes, especially accentuated during deep inspiration. Also, as a general rule, left-sided valve closings are louder than the right valve closing sounds. You normally cannot hear the pulmonic valve close in any location except in the left second intercostal space. The best place to identify the tricuspid valve is along the left lower sternal border. The best and loudest place to hear the mitral valve is at the apex of the heart. The next step of the heart exam is auscultation. Again, when you auscultate, it should be done on skin with the room quiet. And you need to listen again in 5 locations, the same 5 locations that you palpated. Again, first we're going to listen with the diaphragm of the stethoscope. And it doesn't matter what exact order you auscultate those 5 locations, as long as you're systematic and do it the same way consistently. So I'm going to identify the angle of Louis, and first listen in the right second intercostal space, or the aortic area, with the diaphragm. In the left second intercostal space. In the left lower sternal border. And at the point of maximal impulse, at the apex. And then in the epigastrium. And I'm going to repeat all of those by listening with the bell of my stethoscope. You'll notice with the bell, the stethoscope just gently rests on the skin. No pressure needs to be applied. And take your time when you're auscultating. You'll know that there's specific sounds that are heard loudest at certain locations. Again, S1 is loudest at the apex, and S2 is loudest at the base of the heart. Take time to listen in each area and concentrate your attention and focus on the things that you know belong in that area of the heart. And remember to listen in all 5 areas with both sides of your stethoscope. Sometimes you need to do extra maneuvers or positions to bring the heart closer to the chest wall. You may ask the patient to roll on their left side. In fact, you could roll over on the left, about 45 degrees. Exhale completely. Again, this maneuver brings the heart closer to the chest wall and aids in auscultation. You can breathe. Another maneuver would have the patient sit up, lean forward, and exhale, and hold their breath. That would help the examiner hear the murmur of aortic regurgitation better. Also, palpate in the suprasternal notch with your index finger by pressing posteriorly and somewhat inferiorly. You're going to check for any abnormal pulsations or thrills that might come with an aortic aneurysm or a loud aortic stenosis murmur. In conclusion, I hope this video has been helpful in introducing you to the steps that are necessary to assess blood pressure, neck veins, and the cardiac examination. Of course, the only way you become